Hi, I'm Dr. Mitch Shultz at Shultz Chang Vision in Los Angeles, California, and I wanted to talk to you a little bit today about the Tracey iTrace. The iTrace is an incredible device. We use it for so many different things in our practice. We use it for evaluating refractive surgery patients, patients having LASIK, patients who've had previous refractive surgery. But primarily we use it as a great tool for vision assessment, a lot which has to do with our cataract patients. We do a high volume of cataract surgery in our practice, and this tool allows us to evaluate patients to really be able to counsel them about the best lens options they may have. We can also use it for looking at things that affect the visual pathway. And so one of the things that you can see on the screen here today, I'm showing you is the dysfunctional lens index. This is something that we can use practically to counsel patients about where their vision problems are coming from. We can easily assess whether it's coming from the cornea, and you can see over here we have this E. Here, this is showing us where problems are coming from the cornea, or from the inside of the eye. The inside of the eye most commonly is coming from the cataract. However, it could also be coming from the vitreous, so we have to pay attention to whether or not patients may have floaters. And sometimes floaters can affect the DLI as well, so that's really important. When counseling a patient about cataract surgery, we can use this very powerfully because we can demonstrate to them what things look like when they don't have correction, and also when we correct them. So here you can see if we were to correct the patient's astigmatism, they can see much better. And this is a very powerful tool to be able to demonstrate to patients the power of what that astigmatism is doing to their vision. So even if we take out the cataract, which as you can see here, still is kind of fuzzy, even with the correction of the cornea, that cataract has no impact on the cornea. So here we can see that when we have both things uncorrected, you have very blurry E from the astigmatism. So it's important to treat astigmatism in these patients. So I hope you will join me on these next couple of cases that we're going to talk about so that I can show you a little bit about the tools that are available in the iTrace. So the first patient I want to talk to you about is a patient that has just regular against the rule astigmatism. Here we can see that when we look at the Chang analysis, this gives us an understanding of where all the different components of the vision are coming from. So we can see that the patient has astigmatism that is coming both from the cornea as well as from the lens. We can also see that the patient has a fair amount of higher order aberrations that are all being induced by the lens of the eye. So this is telling us that the cataract is fairly significant, and we'll be able to demonstrate that on our dysfunctional lens index. As you can see here, the patient has refractive astigmatism of about 2.5 diopters. That's because some of the astigmatism is coming from the lens. But what's most important is to pay attention to the corneal astigmatism. So here you can see that they still have about 1.2 diopters of astigmatism, which is visually significant. Their corneal spherical aberration is in a really normal profile here. And you can see that the cornea is pretty well balanced with a fair inferior to superior power ratio. Now, when we talk to the patient, we go to the dysfunctional lens index. And on this dysfunctional lens index, this is a great tool for talking to your patients. When you show them this, it really gives them the power of understanding what astigmatism is and how it impacts their vision. So here you can clearly see the patient has a really bad cataract. This is about as bad as it can get. And they have astigmatism. So we can see that the cornea is affected as well as the internal components of the eye, and the total aberration is extremely high. Now what happens if we correct the astigmatism? So we can click on this little button that can demonstrate to the patient what the vision is going to be like should we be able to correct their astigmatism. And here you can see that the cataract is still obviously causing a significant problem, but if we were to correct the patient's astigmatism, he's going to see much clearer than if we don't correct the astigmatism. So this is uncorrected and corrected. So this is a powerful tool to demonstrate to our patients. Here we can see that his angle alpha, or the centering of the pupil and the lens, are very well matched. So we can pretty much choose any type of toric lens we want in a patient like this. Now in our next patient, what we're going to look at is really centration of the eye. So we have a patient coming to us for cataract surgery, and we want to pick the right lens for the patient. Now this is really important because if a patient tells us that they want to have a multifocal or a trifocal or an EDOF lens, they want to be able to see far away, up close, and everything in between, we really have to identify these issues of centration. Unfortunately, in patients that have what we call a high angle alpha D or a high chord mu, when you look at an IOL master, these patients may not be great candidates for the trifocal IOLs. So it's really important to identify that. And in this patient, what you can see here is that angle alpha D is 0.67 millimeters, which is in the fairly high side, and in my opinion, a patient that I would avoid putting either a multifocal, bifocal, or trifocal IOL in this type of patient. I would certainly counsel the patient about his astigmatism and talk to him about the benefits of treating his astigmatism. In this patient, we actually have a little bit of higher corneal spherical aberration. So in a patient like this, I might actually consider a lens that's going to reduce corneal spherical aberration a little bit to enhance their quality of their vision. So I think these are important factors that we're going to talk to our patients about when we look at the Chang analysis. So here's a patient that came to us for cataract surgery. And sometimes our patients are coming directly for a pre-op visit being sent in by an optometrist. And so the first time we're seeing them is actually at their pre-op visit. And unfortunately, optometrists or other eye care providers don't necessarily tell us the full history of the patient. So the patient came in for cataract surgery, and what was very clear on the exam, as you can see here, is the patient has a significant pterygium that's causing astigmatism. It's causing flattening here and steepening here, and that is something that we absolutely want to take care of before we actually do cataract surgery for a patient like this. If we are to operate on a patient like this with the pterygium, that will make our results unpredictable. So when we see our patients that have pterygiums that are affecting vision, I think it's very important that we kind of refocus, talk to them about taking care of this, rehabilitating the cornea to achieve the best outcome for the patient. When we look at the different summaries, we can actually demonstrate to the patient what this is doing to their vision. So again, we can go to the dysfunctional lens index, and what's really important to look at is what the astigmatism is doing to the patient's vision. So it's really important to let the patient know that the pterygium is actually inducing some astigmatism here, and it's going to cause some shadowing that if we don't take care of it, we're not going to be able to get them the quality of vision that they like after surgery. So I think that when we're talking to the patients, you have to demonstrate to them it's not just what's going on with the cataract, but also is there something corneal that we need to address before we deal with the cataract surgery. So this next patient I want to talk to you about is a patient who had prior hyperopic LASIK and comes to me for cataract surgery. She had hyperopic LASIK to achieve excellent near vision in her right eye, and previously had good vision in her left eye for distance, and she wants to achieve the same thing after surgery. So this is something we can do with cataract surgery. I don't try to talk patients out of monovision who were very happy with monovision previously. However, I do talk to them about the different lenses that might achieve the best results for them. So in this patient, as you can see here, they had hyperopic LASIK, so you can see by the topography, the center of the topography is steeper. The center has more yellow, and when we get out to the periphery, it is purple or much flatter. So as you can see, the flat numbers are in the 44 range, and the steep numbers are up to 48. So this patient has a fairly multifocal cornea. The ablation is very well centered. But what's actually really important to understand about this patient is their corneal spherical aberration. It is slightly minus in power. So that's important to understand with the type of lens that we may choose for this type of patient. For these types of patients, we don't want to induce more minus spherical aberration, so we actually want to try to reduce the amount of corneal spherical aberration by modifying with the lens so that we can get more spherically neutral to enhance their quality of vision. The ways that we can do that in a patient like this is to use either a spherically neutral lens, a lens that has positive spherical aberration. There are ways to cause positive spherical aberration in a lens, and one of those new lenses that we have are the light adjustable lenses. So if we actually start from the minus side on the lens and then induce flattening of that lens, we can actually effectively neutralize the spherical aberration because we're going to induce some positive corneal spherical aberration by performing a myopic treatment in the light adjustable lens. So that's one way that we can do that, and that's exactly what I chose for this patient. So post-operatively, we actually purposely made her a little bit more nearsighted and then came back the other direction to enhance her vision exactly to where she wanted and give her that high quality of vision by neutralizing the spherical aberration. So we talked a little bit about different types of things we have to screen for when we're doing cataract surgery. And one of those things is also looking at the ocular surface for symmetry or uniformity. And one thing that can really affect cataract surgery is dry eyes. And so in this patient, what you can see is some inferior steepening, and typically this is caused by the fact that the tear meniscus is low in these patients with dry eye, and so they tend to get punctate keratopathy more prominent in the inferior cornea, and that will actually demonstrate itself as highlighting steepening of the cornea. So I think it's really important to take a look when you look at patients with dry eyes and consult them about the fact that we need to take care of their dry eyes prior to cataract surgery. You can see that this patient actually has a fair cataract, but their cornea is actually relatively good. However, this inferior steepening may influence things post-operatively. So this is actually a patient who I actually chose to send home, treat for dry eyes, and then have them come back once they were ready. So we actually waited about 2 months to reevaluate the patient. And now you can see that when we've treated the patient, their cornea is much more regular, and now they're ready for surgery. And as you can see, they have almost no astigmatism based on the fact that we've now managed their dry eye. So when you're seeing a patient, if you see irregularities to the cornea, you have to think about the different things that might cause that irregularity. Dry eyes, anterior basement membrane dystrophy, corneal scarring, pterygiums like we talked about in the last patient. These are all things that are really important. But dry eye is one of those things that we can treat fairly easily and aggressively with eye drops, but we need to do that, and then we need to reassess the patients before we do cataract surgery.